Good afternoon. I am Patrick Carpo, an echocardiographer from Makati Medical Center, section of cardiology. And it is a definite pleasure to be given another chance to provide you with some practical pointers on a topic which has been getting much needed attention due to the demands of our clinical practice. I renamed this lecture Cardio Oncology 102 since this is meant to supplement my initial postgraduate lecture. I have nothing to disclose. Let me start with this quotation. Heart disease and cancer are two major causes of morbidity and mortality worldwide, accounting for at least 70% of medical reasons for mortality around the globe. The survival of children with cancer has considerably increased over the last decades, with a 5-year survival rate exceeding 80%. In the US alone, there is an estimated 18 million cancer survivors by the year of 2022. Therefore, there will be more patients entering the care of an adult cardiologist. The overall 5-year survival rate of cancer survivors was discussed by Leerink and Associates in his JACC article in 2020. This landmark article is a state-of-the-art review of risk prediction, prevention, and surveillance of chemotherapy-induced cardiomyopathy. The incidence of heart failure within 40 years after cardiotoxic treatment is a whopping 10%. Because of the extensive list of cardiotoxic agents used in cancer treatment, this lecture will focus on the more commonly used chemotherapeutic agents that we encounter in our clinical practice. I will be discussing anthracyclines, specifically doxorubicin, and HER2 receptor antagonists, represented by trastuzumab, because these two agents are commonly used, and both are individually associated with the development of cardiomyopathy. Doxorubicin alone is used in the treatment of hematologic childhood cancers, and the two drugs together in the treatment of breast cancer. Other chemotherapeutic agents will be discussed by our guest speakers later in the session. The association between the use of anthracyclines and development of cardiomyopathy has long been studied and documented. The mechanism is linked with intracellular topoisomerase activity and oxidative stress. This association has been documented in this landmark article by Daniela Cardinali and her associates in the European Institute of Oncology. In her study of more than 2,600 patients with a median follow-up of 5.2 years, the overall incidence of cardiotoxicity is about 9%. The median time between chemotherapy and cardiotoxicity is 3.5 months. Cardiotoxicity is defined as a decrease in greater than 10 absolute points in left ventricular ejection fraction, with an associated decrease in left ventricular ejection fraction below 50%. Very important to note is that in 98% of cases, cardiotoxicity occurred within the first year after treatment. This puts emphasis on the importance of surveillance during the first year after completion of cancer treatment. Cardiotoxicity is associated with the cumulative anthracycline dose and the measured left ventricular ejection fraction at the end of treatment. Early detection and prompt therapy of cardiotoxicity appear crucial for the substantial recovery of cardiac function. Now that we have briefly reviewed and established the association between anthracycline with or without HER2 receptor antagonist therapy and cardiotoxicity, let's proceed with a systemic approach in evaluating a patient on cardiotoxic anti-cancer treatment. This is a consensus article by the European Society of Medical Oncology by Curigliano et al. I believe this is the most thorough and useful review of initial evaluation, surveillance, and initial management of symptomatic and asymptomatic patients on cardiotoxic anti-cancer therapy. This is a must-read for all cardio-oncology enthusiasts, also a good reference for any cardiologist or oncologist. As with most medical cases, a good evaluation starts with a thorough history. I cannot overemphasize the need for these factors to be documented prior to the start of anti-cancer treatment. Our short review of related medical journals will repetitively focus on the importance of highlighting each patient's high-risk factors for cardiovascular dysfunction. Special mention on this list is that of prior anticoagulant treatment, extremes of age, more than 70 and less than 10, prior irradiations of the chest, a low baseline left ventricular ejection fraction, and a history of cardiovascular disease. Some authors have included female gender, other cardiovascular risk factors such as hypertension, smoking, and diabetes, as well as elevated cardiobiomarkers at the end of treatment, at the beginning of treatment. Included in this article is a proposed algorithm for the monitoring and management approach of patients undergoing potentially cardiotoxic anti-cancer therapy. This algorithm begins with a thorough cardiovascular exam and a list of baseline diagnostic tests, which may include the following: cardiac biomarkers such as highly sensitive cardiac troponins T or I, and NT-proBNP, a 12-lead ECG with the corrected QT interval measurement, assessment of left ventricular ejection fraction and diastolic function by echo, including a GLS or global longitudinal strain measurement, and a baseline lipid panel. If high-risk features are present, consider early referral to a cardio-oncologist. Baseline echo studies will reveal any significant left ventricular systolic impairment. If systolic function is depressed, consider cardioprotective therapy. Also consider the use of a non-cardiotoxic second-line anti-cancer treatment. And if this is not available, the use of the first-line cancer therapy with multi-specialty team management. If left ventricular ejection fraction is preserved, then cancer therapy may be started with recommended surveillance appropriate for the drug. The rest of the algorithm is quite controversial because each patient requires a separate individual assessment with a multi-specialty team of medical personnel, which may include, but not limited to, the patient's attending physician, a cardiologist or a cardio-oncology specialist, a hemato-oncologist, and if necessary, a radiologist or surgeon. Therefore, the management may differ from case to case. And for this reason, I will leave it for your reference and forgo its discussion. In this article by Dr. Harry Narayan, he reports that most patients with cardiotoxicity were asymptomatic and left ventricular ejection fraction was only detected by scheduled echocardiographic studies. He adds that in patients who were given doxorubicin and trastuzumab, there is a modest decline in left ventricular ejection fraction at 3 years, even in non-high-risk patients. Changes in volume, strain, and ventricular arterial coupling were consistently associated with concurrent and subsequent declines in ejection fraction. Therefore, monitoring for cardiotoxicity is recommended despite the lack of cardiac symptoms. The two most common parameters used in the surveillance for cardiotoxicity is left ventricular ejection fraction and global longitudinal strain. Evidence for cardiotoxicity is defined as follows. For left ventricular ejection fraction, there should be a decrease by at least 10 absolute points from the previous measurement, associated with a decrease in LVEF below 50%. The relative decrease in GLS by 12% from the previous measurement, or a 5% absolute decrease in GLS. Global longitudinal strain, or GLS, is reduced even in patients with a cumulative doxorubicin dose as low as 100 to 200 milligrams per meter squared, despite a normal left ventricular ejection fraction. Reduced GLS is a predictor of cardiotoxicity 3 to 6 months later. It provides us an opportunity to initiate cardioprotective therapy. However, reduction in GLS alone is usually not an adequate reason to discontinue anti-cancer treatment. For those who follow articles in cardio-oncology, you may be familiar with the American Society of Echo Expert Consensus Report published in 2014. This has provided us a guideline for echo surveillance during anthracycline treatment and trastuzumab therapy. An update review of recommended surveillance schedule was published just last year, 2021, in the Journal of Cardiac Oncology. This review follows the schedule recommended by the ASE in 2014, with the inclusion of an echo evaluation upon completion of therapy and during the post-treatment follow-up. For anthracyclines, echo studies are scheduled at baseline at a cumulative dose of 240 milligrams per meter squared, then prior to each additional 50 milligrams per meter squared, at the end of treatment, and then 6 to 12 months later. For trastuzumab therapy, echo studies are recommended at baseline every 3 months during therapy, then every 6 months after end of treatment for at least 2 years. Long-term post-anti-cancer therapy monitoring should be individualized based on the cumulative dose of therapy and the patient's high risk factors for cardiotoxicity. Once a decision on starting a cardioprotective agent has been made, the clinician has this list of drugs that have some clinical trial evidence to suggest efficacy during anti-cancer therapy. The generic names of drugs listed on the right side of the table indicate some of the representative drugs used in the clinical trials. This include enalapril for ACE inhibitors, candesartan for ARBs, spironolactone for mineralocorticoid receptor antagonists, pravastatin and atorvastatin for statins, the only iron chelator, desraroxazine, and carvedilol, libivolol beta blockers, and a combination therapy with enalapril or carvedilol. My apologies, but my recent readings did not include the trials on antiplatelets like aspirin and anticoagulants like subcutaneous heparin or NOAC agents. I think this may be an interesting topic for future lectures. The following slides will show a short series of landmark articles and some new clinical studies that have been made to substantiate the proof of the use of some of these medications. The Overcome trial is a single trial in Spain involving 90 patients with hematologic malignancies. Patients assigned to receive enalapril and carvedilol showed a significant reduction in the combined endpoint of death, heart failure, and final left ventricular ejection fraction of less than 45% at 6 months compared to a placebo. In another single central trial in Norway, we know this is the Prada trial, with 130 patients undergoing anthracycline-based therapy, with or without trastuzumab or irradiation. They were independently randomly assigned to receive candesartan, metoprolol, or matching placebo in a 2x2 factorial design. Candesartan and metoprolol did not show preservation of left ventricular ejection fraction at 2 years by the year 2021. In contrast to an earlier publication in 2016, when candesartan but not metoprolol initially showed left ventricular ejection fraction preservation in the assessment of early outcome. However, in this study, candesartan did show association with modest reduction of left ventricular end-diastolic volume and preservation of GLS. This study suggests that cardioprotection may not be required in most patients with early breast cancer treatment without pre-existing cardiovascular disease. A separate study on patients with high-risk factors must be performed to verify the utility of prevention of cardiotoxicity in this specific subset of patients. In the Manticore trial, 94 patients were randomized to perindopril, bisoprolol, or placebo. Preservation of left ventricular ejection fraction was observed in both perindopril and bisoprolol. There was no statistical difference in preventing left ventricular remodeling or change in volume, which were the primary endpoint of the study. The CECCY trial, which stands for the Cardiologia for Prevention of Chemotherapy-Related Cardiotoxicity, is a randomized placebo-controlled trial of 200 breast cancer patients on anthracycline treatment. With carvedilol treatment, there was no difference in left ventricular ejection fraction documented, but there was an improvement of diastolic function and protection from troponin elevation. This study by Dr. Guglin and associates showed that in HERS2 positive patients treated with anthracycline and trastuzumab, both lisinopril and carvedilol were effective in preventing cardiotoxicity. In 82 breast cancer patients on anthracycline therapy, a study by ACPEC and associates showed that aldosterone antagonist spironolactone improved left ventricular ejection fraction compared with placebo. Desrozoxane is an iron chelator, which may be reduced in the production of free radicals, which may reduce the production of free radicals formed at the time of anthracycline therapy. In this study by Dr. Macedo, it was concluded that at the beginning of anthracycline therapy, especially if the patients required doses greater than 300 milligrams per meter squared, treatment with desrozoxane may be reasonable. It has been suggested in previous studies, specifically by Toll and his associates in Nature Journal in 2017, that hyperlipidemia has a contributory effect to the inflammation in patients with cancer. This prompted focus of antioxidant effects of statins during anti-cancer treatment. This propensity-matched cohort study of 200 patients found benefit of continuous statin treatment in patients with breast cancer treated with anthracycline. And this small randomized study of 40 patients receiving anthracycline treatment by ACAR and associates suggested a beneficial cardioprotective therapy of statin use. However, a prospective trial called the PREVENT study is currently ongoing to prove this hypothesis. There are many other substantial clinical trials on cardioprotection in the setting of anti-cancer therapy. There are too many to include in this talk. Cardio-oncology, however, is not just limited to anthracyclines, HERS2 receptor antagonists, and cardiomyopathy. For example, there is an association between VEGF inhibitors like bevacizumab, or known as Avastin, and hypertensive urgency. There's also an association between 5-fluorouracil and coronary vasospasm. Tyrosine kinase inhibitors, or TKI, such as sunitinib and lapatinib, have been associated with prolonged QT intervals and ventricular cardiac arrhythmias. We encourage you to continue to remain updated on these subjects, and we can help you the best way we can. As a reminder, let me bring up the important points of this lecture. Patients with high-risk factors for cardiotoxicity benefit the most from cardioprotective therapy. Close surveillance for cardiotoxicity is crucial in the first year after completion of anti-cancer treatment. Cardioprotective therapy may be initiated prior to anti-cancer treatment in patients with high-risk factors for cardiotoxicity, in patients with subclinical evidence of left ventricular systolic dysfunction by GLS, or by a significant decrease in left ventricular ejection fraction even without overt clinical heart failure symptoms. A referral to a cardiologist or cardio-oncology specialist is recommended early in the care of these patients. As I near the end of this talk, I would like to thank Dr. Su Lokman, Kay Tan, and Ava Chu for your continued support and advocacy in cardio-oncology. I would like to end this lecture with a quotation from Ganatra and colleagues on this article on what he refers to as Gen Next, or the next generation. Education of healthcare providers, particularly the next generation of cardiologists and hemato-oncologists, along with patients, on the importance of cardiovascular health and anti-cancer treatment should translate into better cancer and cardiovascular outcomes. In this slide, I'm extremely proud to introduce to you our very own Gen X cardiologists. Discussing a few of other cardiotoxic anti-cancer drugs in clinical practice are our incoming research fellows in cardio-oncology, Drs. Crizel Ozaita and Rene Ong. Thank you very much.
Thank you, Dr. Carpo, for that very informative lecture. And going further, I, Dr. Cristina Ozaita Lorilla, and Dr. Renato Ong will be talking about the other side effects of chemotherapy related to the cardiovascular system. We must keep in mind that the effects of chemotherapy is not limited to cardiomyopathy. Cardiotoxicity incidence and pathophysiology differ. It depends on the type, cumulative dose, and administration schedule of antiblastic therapy. The use of numerous chemotherapy drugs is associated with adverse cardiovascular effects, such as vasospastic and thromboembolic ischemia, hypertension, dysrhythmia, myocarditis, and left ventricular dysfunction leading to heart failure. Among these drugs, anthracyclines have been studied most extensively because of their ability to induce cardiac injury, particularly heart failure. However, cardiotoxicity might also be caused by other classes of chemotherapeutic agents. Alkylating agents like cyclophosphamide can cause myopericarditis due to the direct endothelial injury, as well as cardiac tamponade due to oxidative stress and mitochondrial damage. Platinum-based compounds like cisplatin, carboplatin, and oxaliplatin can cause arrhythmias due to mitochondrial ultrastructural abnormalities. Myocarditis, acute myocardial infarction, hypertension or hypotension, and increased thrombotic events due to increased platelet activation and aggregation. To discuss further about the other side effects is Dr. Renato Ong.
Gradual decline in diastolic parameters after cisplatin-based chemotherapy for testicular cancer was found in one cohort study. Several cancer treatments are associated with the development or exacerbation of hypertension as listed in the table to your left. Hypertension is the most common severe adverse event in patients receiving cancer chemotherapy. Antimetabolites like 5-fluorouracil and capecitabine can cause angina-like chest pain due to coronary artery thrombosis and ventricular tachycardia due to the oxidative stress in myocardiocystes and endothelial cells. Coronary artery vasospasm is a recognized side effect of 5-fluorouracil. In a retrospective analysis conducted by Zafar et al. From approximately 4,019 individuals who received 5-FU, there was no significant difference in progression-free survival, overall mortality, or cancer-specific mortality between patients who developed vasospasm versus those who did not. Likewise, many oncologic therapies like tyrosine kinase inhibitors imatinib, nilotinib, and dasatinib can cause QT prolongation from citrate accumulation and Krebs cycle alteration. Antibiotics like bleomycin and mitomycin C can cause diastolic dysfunction due to damage of mitochondrial respiratory chain and impaired energy metabolism. Antimicrotubule agents like paclitaxel and docetaxel can cause myocardial ischemia from damage on the Purkinje system or autonomic control, as well as atrioventricular blocks and left bundle branch blocks from enhanced metabolism of doxorubicin toxic species. Establishing a causal relationship of a certain chemotherapeutic agent to a specific cancer treatment-induced arrhythmia can be very challenging. First of all, cancer itself can predispose to arrhythmia. One example is atrial fibrillation or flutter, with the overt manifestation of the arrhythmia sometimes preceding the diagnosis of the malignancy. Chronic inflammation, metabolic changes induced by cancer, and the presence of common risk factors such as obesity and alcohol use are the most plausible explanations for this association. The absence of cardiac monitoring prior to chemotherapy in most trials makes it difficult to determine whether there was a pre-existing underdiagnosed arrhythmia rather than one related to the chemotherapy. Second, most chemotherapy protocols include multi-drug regimens which make the identification of the exact causative agent difficult. In addition, a synergistic effect of multiple drugs on cardiac toxicity profile cannot be ruled out. Many patients also have a history of prior treatment for cancer, which makes it difficult to determine whether the arrhythmia is secondary to the current regimen or a chronic effect of past therapy. Third, CTIAs in clinical trials are often described as symptoms, and the exact diagnosis of the underlying arrhythmia is often not available. It's an age-old question as we return to work from a year-end of break. What lies ahead as we veer towards the emerging trends in cardiovascular medicine? It's cardio-oncology. Thank you very much for this opportunity.